Okay, morning to you all. Welcome. My name is Brett Edwards. I'm the National Chair for NASHiCS, National Association for Safety and Health in Care Services. Welcome to our first webinar of 2024. I'm sure there are many of you that I haven't seen since the Christmas season and New Year. So Happy New Year to all of you, and I hope that this year is going well so far and continues to do so. We have our webinar today. As I've already said, this is being recorded. This webinar is on positive behavioural support. The presentation and the recording will be available within the member section of the NASHiCS website, and that will be in about a week's time. If I could ask you all to mute yourselves, that would be fantastic. And that just stops on any feedback. The presentation will finish at 11 o'clock. It should be approximately 40 to 45 minutes, and then there will be opportunity for you to ask questions. If you have any questions during the presentation, please could I ask that you put those into the chat so that we can collate them. Equally, it means that if we run out of time, we don't lose those questions, and then we will send out a Q&A crib sheet for all of those people that have attended. If, however, you've got any questions for clarity during the presentation, please feel free to raise your hand using the reactions that you'll find at the bottom of your screen, and we will happily pause for a moment to give clarity on that information. As I say, it will be about 40 to 45 minutes of presentation, and then we will go on to some questions if we have chance. And I will also remind you of dates for the diary for the remainder of 2024 for NASHiCS events. And that just leaves me to introduce Joe Lioba. Hopefully I said that correctly, Joe. Joe works for Lifeways and is a specialises in positive behavioural support and reducing restrictive practices. I'm not going to continue to talk. I'm going to hand over to Jo so that she can continue with the presentation. So Jo, over to you.
I'm Jo, as Brett has already introduced me. I've been working in the field of positive behaviour support for the last 10 years. My academic background is in psychology and positive behaviour support as well. The reason I chose positive behaviour support as my career and as my passion and my focus is that I started my career in social care in mental health secure services, and unfortunately there was a very large percentage of individuals who were autistic or had learning disabilities, and they were living in these services in environments that just didn't work for them, which meant that behaviours were continuously escalating, and some of those individuals would be there for 7, 9, 10 years, and it was never felt that they were ready to move out into the community. So today we're going to talk a lot about PBS. We're going to talk a lot about behaviours that challenge. And Brett, if I can get you to skip to the next slide. Fantastic, thank you. There's a lot of terms out there. I'm sure you have heard challenging behaviour, behaviours that challenge, behaviours of concern, of distress. The reason we no longer use challenging behaviour is because it marks the behaviour as challenging, and what we're trying to do is shift the focus to the fact that the behaviour challenges systems, challenges the environment, challenges teams. It's not the person themselves that are challenging, it's how the systems around them are not able to accommodate those behaviours. There are two main definitions around behaviours that challenge, and I think the preferable term is behaviours that challenge or that may challenge. Both definitions, I'm not going to read them to you. I'm sure you're very capable of reading lengthy writing, but they refer to behaviours of intensity, frequency and duration that have significant impact on the individual's safety and quality of life. There's a high likelihood because of these behaviours that the individual will be restricted from accessing parts of the community, living a fulfilling life, and also quite possibly be subjected to restrictive and aversive strategies and punitive approaches. And I think we can all recognize that where we do have individuals with behaviours that may challenge, quite often we will have a large amount of restrictions in place. And when we talk about restrictions, we don't just talk about restraint, we talk about restrictions within the environment. That by itself will have an impact on quality of life. And when we have unhappy individuals with low quality of life who cannot get their needs met, we then have an increase in behaviours. It creates a little bit of a vicious cycle where we have to break that cycle and start fixing some of these components to have a positive impact on behaviour. Brett, if I could get you to the next slide. So where are we now? These are just some of the statistics out there. There's a lot of statistics and studies out there in terms of behaviours and incidents, but approximately 50% of people with learning disability and challenging behaviour are subject to physical restraint. Just in July 2020, there have been 4,810 recorded incidents of restrictive interventions. So we're talking physical restraint, prone restraint, which is the floor restraint, mechanical, things like splints and straps, and chemical restraint, which is the use of psychotropic medication, be it by tablet or intramuscular. 70% of homes recorded at least one incident of challenging behaviour by residents, 22% more than 10 in the same period. Approximately 67% of NHS workers experience aggressive behaviour at least once a year, 19% once a week, 3% every day. I think, again, we can all acknowledge that these numbers are probably a lot higher across social care because not every provider will provide reports. And in my experience, also your data is as good as your reporting is. And sometimes restrictive practices become part of the culture, become kind of, it's behavior, it's how the person acts, and we don't necessarily record and report on them. And I have come across colleagues in services who are not aware that some of their practices can be deemed quite restrictive. Moving on to the next slide. We have seen examples of that. We have seen examples of that come up in the news. We have seen examples of that come up in government reports where there's been systemic failures to provide a safe space for patients from abuse and improper treatment, where we have seen abuse and human rights, including physical and emotional abuse and excessive use of restraint and seclusion, where we have not been able to manage safely the risks to patients' well-being, and where we've seen a culture of abuse and punishment. We've seen Walton Hall, Winterbourne View, Coston Park, Edenfield Centre, and there's so many other services out there. We see it through whistleblowings, we see it through safeguardings. We have to think that when we see those reports come out, the focus quite often is not on the behaviours. It's quite easy to mark the behaviours as challenging, but actually the focus of this report is identifying the cultural issues that I'd like to think none of these staff members would act like that within their homes with the people they care and their family members. But what has led to these behaviours happening within a service, within the confines of vulnerable people with learning disability and autism, and potentially also secondary mental health conditions? And how are we still failing to put things in place to improve those cultures and address blanket restrictions and actually stop using disproportionate reactions to these behaviours? We talk about staff stress level and staff performance, and what affects staff performance. And in the next slide, there is a great study that looks at how is the performance of staff within a service affected? Obviously, we have the characteristics of staff themselves, the demographic characteristics and the personal factors, but also we need to think about the culture of an organization, both informal and formal, and the support that we provide as organizations to our staff teams, the training, the coaching, the supervision, and the values that we put in place when we bring new people in. To then be able to translate that into good quality care. And what we want to see in services, whether there's behaviours that challenge or not, we want to see warm interactions. We want to see time spent meaningfully in activities. We want to see safe environments and not aversive and restrictive and punitive strategies being the first point of call and the first response that staff will think of. So we have a responsibility to keep our staff safe, absolutely. Providing a safe working environment is a legal requirement, but we also have a responsibility, and it should be our highest priority, to create environments that are fulfilling and rewarding, and then provide the right support for staff. So we stop focusing on just reacting to behaviors and restricting and controlling behaviors, and actually how can we create positive, capable environments? And I will talk further on about capable environments. So what is PBS? What is Positive Behaviour Support? We love our 3-letter acronyms. You'll see on the next slide, there's a great definition by the British Institute of Learning Disability. Essentially, PBS is a framework. It is not a single approach. There's a misconception that PBS is a single approach that just PBS practitioners can apply within a service. It is a person-centered framework. It's about providing long-term support for people. It's not a quick fix. PBS is not a quick fix. Someone will come in, fix it, and then walk away. It is a long-term approach. It's a systems-driven approach. It has been developed for individuals with learning disabilities, autistic individuals, and mental health conditions who may be at risk of developing behaviours that challenge. And that's really important to take into consideration. PBS is not just for individuals who are already at crisis, already presenting with behaviours that challenge, because by that point, it is too late. It takes too much resource to try and stabilize that situation. Actually, we should be applying PBS across all our services in a positive and proactive way to avoid behaviors that challenge from occurring, to increase quality of life, make sure we maintain good quality of life where we do have it. It is about involving individuals in decision-making, involving stakeholders in decision-making, and it is a values-based approach. PBS as a concept emerged in the 1980s, where we had individuals with intellectual disabilities living in large institutions where punitive approaches, aversive approaches were quite common. Staff were doing the best, but as we know, those services were created to isolate people away from the community and provide a basic level of care of keeping them safe. But in terms of therapeutic input, there wasn't much. And in terms of managing behaviors, unless individuals were very much restrictive and punished for them, there wasn't much else to support, especially when it came to sort of injurious behavior. So as an example, I supported an individual in their 70s a few years ago who, when I sat with them, they were presented with two main behaviors. One of them was trying to bite, and the other one was smearing behaviors. And staff wanted to lock doors, take things away, use restrictive intervention. And actually, it was a conversation of, okay, judging from the age and the fact that this individual has lived within social care settings most of their life, looking back at their history, it transpired that they did come out of one of those long-term institutions because they used to engage in biting behaviors, biting others and biting themselves. Their teeth were removed, and the smearing behavior was a way to keep people away from them. So if we were to react in a restrictive way, without understanding their history, without understanding their past, we would actually be further punishing them for a behavior that they developed because of their history, because of the way care was at that time. at that point in time. So we have a responsibility to provide care that honors human rights, and it's a dignified approach. And this is pretty much what PBS is all about. On the next slide, you'll be able to see there's a very good report, Positive Behaviour Support in the UK, a State of the Nation report. There is an international journal for Positive Behaviour Support, and a lot of the resources are available to the public without a subscription. PBS is not a single intervention, as we said. It's a framework approach. It brings a lot of components together, and a lot of us, I'd like to think, do most of them. Some of them, most of them, but PBS brings all the pieces of the puzzle together. And we will go through these components. I can talk about each of these components for hours. I will try and keep it short, but we will go through these components individually. But it is about understanding. It's not a magic wand approach. It's not a single intervention. This is about a system, a framework, and how it all comes together to improve quality of life, and by extent, reduce restrictions, the need for restrictions, and behaviours that challenge. So when we look at rights and values, yeah, excellent. Thank you. So when we look at rights and values, obviously we're looking at person-centered care. We need to place the individual in the center of all our decision making. We need to take into consideration their needs, their aspiration, their wants, their skills, their strengths, their history. And I know sometimes when we support individuals who are non-verbal, where there's a severe learning disability in place, that can become hard. But that's not to say we can still not offer choice, take their own behavior into consideration, the things we know they're like, and get the knowledge from the carers as well when we drive those decisions. The aim should be to improve quality of life. Again, the aim of PBS is to improve quality of life. It's not to control behavior. It's not to restrict behavior. It's about providing good life and meeting a person's needs, because if needs are met and we provide tools for an individual to meet their needs, it's less likely that they're going to try and display behaviors to get that communication attempt out. And that ties into the second value as well. We're looking at constructional approaches and self-determination. I'll have to ping you back, Brett, the slides. Thank you. It is about, essentially what that means is about building skills. A lot of the time, again, with intellectual disabilities, there is severe lack of independent living skills, of communication skills, decision-making, choice-making skills. And actually, these are skills we should be investing on. These are skills we should be focusing on and working towards to enable individuals to make those decisions, rather than focusing all our attempt on restrictions and identifying where we can risk mitigate continuously. It's about, let's teach the skills. If a behavior is trying to meet a need, let's teach the right behavior to meet that need. Let's replace them. But actually, let's teach skills that can be taken further into life. And it's about partnership working. And we know the new Care Quality Commission inspection framework will look at stakeholder opinions and stakeholder participation and carers' opinions and participation. And that's where all our knowledge comes from. When we have individuals who move across social care, move across different counties, information gets lost very easily. We find they come over to us with very minimal paperwork. We have to get to know them from the start. And it can be very frustrating when you're in care as a person to have to be supported by individuals who don't know you, and they take time to know you every single time. It's very hard to build rapport that way. So we need to be able to communicate with stakeholders and carers and get all their knowledge, all their expertise, get the history of the individual from them, make them part of our assessment, part of our reviews. And we need to have open, transparent cultures where we can share information, share our lessons learned as well, and get that buy-in as well. So now we will talk about restraint reduction, and it's a big part of positive behaviour support, in that excessive use of restraint will have an impact on quality of life. The restraint reduction network standards came into effect, I believe, in April 2021. The social care sector is still catching up with them, but it is a framework. Again, they aim to improve quality of life for people who are being restrained, and the staff and the carers supporting them. It's about reducing reliance on restrictive practice and actually promoting positive culture, removing blanket restrictions, focusing on prevention, de-escalation, building skills, meaningful engagement, and reflective practice. It's about increasing understanding about what the root cause of behavior is. So instead of just constantly reacting to the behaviors, is understanding what the person is trying to communicate and meeting that need for them before the behavior occurs, which we should be doing. That should be the focus of how we provide care. And there are times when restraint will need to be used to keep a person safe, keep others safe. We acknowledge that. We know it's part of our role sometimes, but when that does happen, we need to make sure we have a training needs analysis in place. That training needs analysis identifies the behaviors of the individual, the frequency of these behaviors, what these behaviors look like, and for anything that is prescribed as a restraint, it needs to be person specific. We need to make sure we have done the mental capacity assessment. If the individual doesn't have capacity, we have to go through best interest. We have COP doors in place. It's not just a case of training a whole staff team on restraint on the same intervention or the higher level of intervention, and they only use what they need, because research and experience have shown us that staff will use everything excessively, because it's a skill they have, and it's a skill that's there, and sometimes it becomes the first point of call when it should be the last. So the RRN standards expect us to be able to evidence that we have gone through this process, and we're taking into consideration individual needs. We review the needs of the person annually, or as a reactive strategy after an incident, for example, but we are responsive and we are proportionate, and we only use what is reasonable and necessary. Now, do the RRN standards apply to you? The quickest way to answer this is that if you're an NHS-funded organisation or you're inspected by the Care Quality Commission, yes. If you have staff to use clinical holds to provide medical interventions or personal care, and that you provide training on physical restraint, and there's a lot of providers out there, NAPI, MAPA, Teams, GSA, that there's so many, more than I know, then yes, that you do need to be compliant with the RRN standards. You need to be able to evidence that you're compliant with the RRN standards. The membership is free. I'm not here to promote them, I promise. The membership is free. You can have individual pledges or organizational pledges, and the RRN network website has a plethora of resources you can use as well, that they're not just about physical restraint, but also use of restrictive practice across services. There's auditing tools, there's easy rate staff. I cannot advise you enough to take an individual pledge and look through those resources. They're really useful. They're standardized tools, and a lot of professionals out there have come together to work on those standards. Okay. So moving on from values and theory, we'll move into theory and evidence-based. So this is about understanding behavior, understanding how behavior is shaped, how behavior emerges, and how behavior continues to happen, because we have seen it. Even when punishment is used or aversive strategies are used, it doesn't change behavior from happening. If it meets a need for an individual, and chances are they'll find a different way to achieve the same outcome. And if we don't teach the right skills, it will just be a different behavior with a similar negative impact. So PBS uses a biopsychosocial model. When we say behavior happens for a reason, there could be biological reasons for this behavior, genetic factors, the person's gender, the person's age. It could be psychological reasons, self-esteem, confidence, trauma. Trauma trauma is coming to the focus of everything we do. And then it could be social factors as well. The family home where an individual has been raised, the social care homes where they have moved throughout their life, their learning history, the people they have interacted with. So it's not a single thing that shapes behavior, it's the contingencies around us, and we need to know those things to be able to change behavior. And that's where the behavioral approaches come into the focus, into the spotlight. PBS uses science, uses standardized science from behavior analysis to understand behavior and to change behavior. We call it the ABCs of behavior, the antecedent, behavior, consequence. But in order to change behavior, you need to understand the principles of behavior, what shapes and motivates us, or doesn't motivate us from engaging in certain behaviors. And also, PBS is not a single profession intervention. Yes, there are PBS practitioners out there that have the skills and expertise to implement quite high-level PBS plan and bespoke behavioral strategies. But PBS is something that anyone can do. PBS is something that a lot of professionals can provide input in. And what we also need to stop saying as PBS practitioners is that we have all the knowledge, all the behavioral knowledge around PBS, because we need that input from occupational therapy, we need the input from psychology, from psychiatry, from speech and language therapy, and all of us professionals need to be able to sit around the table together and have those discussions and create a plan together that actually consolidates everything in one plan. I know your experiences are probably the same when staff have to look at a speech and language report, and then in a second folder look at an OT report, and in a different folder look at a psychology assessment, and a plan from learning disability teams. It becomes very difficult to keep track and increases the risk of missing information, not processing information. So we need to be able to bring all these professionals together and combine that knowledge and actually make sure what we recommend aligns and it works within the same framework. It is about collecting data and not collecting data for the sake of collecting data. It is about what do we do with that information? Who sees it? What lessons do we learn? Who do we share it with? If there is ABC data, if there's incident and accident data, what do we learn from that information? We need to be able to pull that information from services, auditing information, health and safety information, and bring it all together so we identify what works, what doesn't work, where can we make improvements, where are our quick wins, where do we need to invest additional resource. And it's about creating capable environments. There's a great study by McGill. You can find the capable environments checklist on the Build website, and I highly encourage you to. But anything around us is the environment. So when we talk about environment, we need to just stop thinking about the floors, the ceilings, and the walls, and the furniture in a home. It's about anything outside the individual. How are we supporting the communication needs? How are we implementing tools to support these communication needs? The training of our staff, the competence, the skill of the managers in the service, the training of the managers themselves, the leadership, the organizational support. How are we creating environments that we can engage in activities if the kitchen is constantly locked? If the activity resources are locked in a cupboard for safety, if staff if there isn't adequate staffing levels in the service to be able to facilitate activities, if people with support sit on a chair in the living room watching the TV while staff do the shopping, put the shopping away, do the cooking. So it's about creating environments that encourage independence and decision making and choice. And then bringing all that information, again, we have all this information, all this data, but it can't be data for data's sake. We need to be able to bring those in together, create a bespoke assessment, and create positive behaviour support plans. And it needs to be positive behaviour support plans that have a primary focus on positive, proactive strategies, not just responding to behaviours. It's about how are we facilitating communication for that individual, for them to understand us and for us to understand them. How are we changing the environment to fit their needs? If there is sensory needs, how are we meeting their health needs? Because we don't want individuals to become unwell and start displaying behaviours for us to understand there's toothache, there's a UTI, there's medical condition going on. How do we adapt our environments to make sure active support happens and there's opportunities to engage throughout the day? We break down the tasks, and none of these things have to do with the challenging behaviors. These are things we can have in place to create happy lives, to create good quality of life. And then when we do have reactive strategies, we need to make sure that we have done the assessment, we have taken the information from stakeholders, we use the least restrictive option, and we can still respond to behaviours without using aversive strategies, without using punishment. It's about identifying all that and bringing it together. Now you'll see on the next slide, not everyone is going to need the same level of intensive support. And that's why we say it's not a single profession. Everyone across the organization can do PBS. What we want to see is that universal approach of a positive culture where staff have PBS training, active support training, there's capable environments, there is an understanding that behavior has a function. So when we do start seeing behaviors, we understand that the individual is trying to communicate something. If I'm constantly being grabbed and dragged to another room, I shouldn't be worrying about, oh my God, I'm being grabbed. It's about where are they taking me? What are they trying to communicate with me? And why am I not trained enough to understand what this behavior is trying to communicate to me? So understanding that behavior has a function. Make sure we have a trauma-informed support. Individuals have been exposed to some very traumatic events in their life, from placement breakdowns, different carers, multiple restraints. These are very traumatic events, and they can change how we build relationships. And then we also have staff who are exposed to traumatic events and have their own learning history. So what we don't want to have is staff with trauma themselves, supporting individuals who have been exposed to trauma and experienced trauma themselves without that support about what is trauma-informed care. And it's about facilitating communication. I think it's fair to say that wherever we have individuals that are not able to verbally and vocally communicate with us, we need to have tools in place to facilitate that. So the majority of the people we come across in social care will sit at that universal level. There is a small cohort that might be a little bit more complex, so they will need the universal level and the additional support. And that's usually when PBS practitioners tend to come into play. They will provide functional assessments, they will provide function-based PBS plan and individual strategies in key areas. And sometimes that's not enough either, because we have those highly complex individuals where they've had multiple placement breakdowns because people just struggle to get it right. They burn through staff teams because staff don't have the right skill set, or it could be that the behaviors are so severe that we really need to put that focus support in place. And that usually happens with self-injurious behaviors. And that's when we need to focus our biggest specialist resource. That's when it becomes specialist. That's when we need the MDT to come around and put the assessments, their knowledge, their expertise together in a plan. We need to look at multi-element plans, specialist behavioural interventions. We need to continuously be monitoring and evaluating those interventions. So even if you don't have a specialist PBS resource within your own organizations, it doesn't mean you cannot do PBS. Okay, I will move on to the next slide. Fantastic, thank you. PBS is not a quick fix. It's not a magic wand. It's not a single intervention. I know I keep repeating it, but these are things we come across quite often when we get called into services. It takes an organizational commitment. It takes the right policies and procedures in place. A PBS policy should be in place. A restraint reduction policy should be in place. It takes different departments and function and support functions to be able to talk to each other and work together in terms of observing and monitoring and evaluating PBS. We work quite closely with our health and safety and quality team because we want to make sure that when individuals outside my specialist support team go into services, they can very quickly assess if we're doing PBS right. It's about the training and the resources being right. There is a number of frameworks out there when it comes to specialist training. PBS training, the PBS Academy framework have worked with different providers, including Skills for Care, and they have created the PBS Academy framework, which outlines what good PBS training should look like for direct support staff. And if you do have that training within your organization, you can also have it endorsed by Skills for Care. It's about having the right resources. I don't think as providers we share resources enough. We tend to be very protective of resources, but there's a great amount of tools out there through Build, through RRN, that can be used to assess what does good PBS look like. Are your services PBS ready? What should we be looking at, and where can we focus our efforts and support? It's about data monitoring, tracking incidents, learning from incidents, looking at patterns in incidents, and actually who's monitoring those incidents. We find that we monitor incidents daily, weekly, and it helps us identify those early warning signs that something might not be going quite right in a service, and be able to provide that quick training and specialist support to make sure that things don't escalate so far that we have to be at crisis level. And it's about debriefs as well, and looking after our staff teams. And I'm separating learning from debriefs, because debriefs should focus on the therapeutic approach, should focus on making staff feel safe and secure to come back to duties, and support those individuals. And it's about the people we support having the opportunity for a debrief as well, to talk about their feelings, what has happened. Again, we need to be thinking trauma-informed support. So what we want to achieve is we want to move away from the carrot and stick situation where we constantly reward good behavior. And I've seen it happen with treats and biscuits and Smarties, and let's go out, and if you're good, you can get a takeaway. But if things are bad, you will not go out again. We will strip the room. And these are all practices I've witnessed. I'm talking from personal experiences from years in secure services, residential, supported living. I've worked in all of them, and I supported referrals in all of them. And it is not about shift the focus away from just controlling behaviors that challenge and managing behaviors that challenge, and actually shift the focus of the scales on lifting and improving the quality of life. And we will see that as quality of life comes up, engagement and activity goes up, behaviors that challenge will start reducing. So why PBS? Out of all the interventions, for me, it's because it combines all these interventions, and it doesn't think of itself as the one panacea for behaviors that challenge. It's recommended by a number of governing bodies, and such as Royal College of Psychiatrists, Care Quality Commission, British Psychological Society, Institute of Learning Disabilities, and the RRN network. I highly advise, as you get access to these slides, to look through those publications as well. But it is recommended in a number of government reports and policy statements as well. And in Wales, PBS is a key recommendation as well when it comes to supporting individuals with learning disability and behaviours that challenge. So, next slide, please. Thank you. Oh, skip that as well. Don't want to be reading to you guys, and I'm conscious of the time as well. So, okay, you're doing PBS, amazing, but what does it look like? And what would individuals who come into your service and look at your PBS practice be looking for? So this is just an example, but the Care Quality Commission have released a couple of papers where they outline in detail what an inspector will be looking at when they're looking at how you apply PBS within your service. It's things like the quality and assessment of your PBS plan. Are the PBS plans focusing on, as we said, the proactive strategies, the good stuff, the positive stuff, or are they just focused on behaviours and how to restrain and how to control and restrict behaviours? Actually, do staff understand? Are staff competent and can talk through those strategies and can explain and can show themselves and model using those strategies? A PBS plan is only as good as the people that use it. We need to make sure that staff are familiar with those PBS plans. Then we also need to make sure that we monitor the implementation of those PBS plans. When audits happen, we need to make sure that audits look at not just the existence of a PBS plan, but the quality of the plan. Is it in date? Is it person specific? Is it individualized? Have staff signed, and do staff look like they understand the strategies within it? But also, have we provided time for staff to understand PBS? It's very easy to judge staff approaches and staff culture, but I like to think our staff teams are as good as the knowledge we provide them as organisations and the training we provide them as organisations. So can we evidence we have provided the right level of PBS training? Can we evidence in supervisions, in debriefs, in lessons learned, that we have spoken about PBS, we have factored PBS into our decisions? Have we allowed that protected time where we can have those discussions? And then we need to look at where is the evidence of involving families and carers, your service, your best interest meetings, your review meetings. Do you talk about PBS? And then, do we look at restraint reduction within an organisation? If you're an RRN member, chances are you'll have to produce a restraint reduction report annually. So we need to be able to evidence we're monitoring incidents, we're monitoring the use of restrictive practices, the training needs analysis, and we only prescribe what is proportionate. Okay, so what does it look like? Where else can we look at evidence outside of just what CQC inspectors might be looking at? We need to have an accessible annual report, as I said, that provides information on reduction in the use of restrictive practice. We need to make sure we have supervision records, feedback records, debrief records that show the principles of PBS and the values of PBS. Evidence competence training in PBS or relevant legislation, up-to-date risk assessment that actually speak to the PBS plan and they align together. And something I quite encourage my PBS practitioners to do is to work with managers on those risk assessments when it comes to behaviour and make sure we reflect that positive culture and we avoid blanket restrictions. Quality monitoring of the PBS plans, I would say auditing of the PBS plans, they're there to be open and shared and reviewed. And we need to be able to share data, not for data's sake, as we said, it comes back to data, not for data's sake, on staff turnover, staff sickness, staff satisfaction, including how we organizationally respond to it. So to quickly bring all this together, there's a quote I like to use that you'll see on the next slide, in that when a flower doesn't bloom, you fix the environment in which it grows, not the flowers. When individuals in our services are struggling, when we see behaviours that challenge, when we see staff teams being burned out from those behaviours, mistakes happen, it's not a case of serving notice and moving to an individual to another service where these behaviours will probably still remain, and they're stuck in a constant loop of placement breakdowns that become more and more traumatic, and it's harder and harder to manage them. It is about how can I change the environment to meet the person's needs. You know, we would move our plants, and I'm a plant mom, so any excuse to use a plant in my presentations, but we would move our plants to get more sunlight, get more water, feed them better, feed them rest, repot them, and we need to think, what can we change in our environment when we are not happy to make ourselves happy again? We go on holidays, we redecorate, we speak to friends, we bring family in, and we need to start thinking like that. So instead of thinking it's the end and nothing works, is okay, what can I change around me and around that person and make it work? Because we can't make it work. It's not a single person's responsibility, it's all of our responsibility. And there's a lot of professionals out there that can be brought around the table to achieve that. So I have left my email at the end of this presentation. I have also put some of the bodies, representatives and advocates for PBS out there and restraint reduction. By all means, feel free to email me. I know I have literally 3 minutes left, but feel free to contact me. I'm always happy to share resources or point you in the right direction. But I hope this helped clear some of the myths around PBS and create a better understanding about how we can work PBS within our organizations. And yeah, that's it. Thank you so much. We lost the bread.
I am, no, it's right. I am coming. It's a process of clicking a good many buttons, I'm afraid.
I was just looking, thinking, oh, 2 minutes, 2 minutes.
Oh, thank you. That was excellent. And certainly, I know we talked before the presentation when we actually got it working between us. But I mean, certainly we were talking about a lot of the elements there, and certainly that person-centered approach, which is definitely what rings out for me. There were a couple of questions, and I appreciate some people have had to disappear because they've got other meetings. We will overrun by a couple of minutes, as I'm sure you'll appreciate with the technical hitches. But there were a couple of questions that came in. First one, Joe, was do the RRN standards apply in children's services?
They apply for young people, but I think obviously there's a difference between the mental capacity assessment and restraint. It's a little bit more liberally used within schools, but the principles are the same. We need to be able to evidence that we don't use blanket restrictions. We do not inflict very traumatic high-level hold to children who will then move on to life to take that with them, and break that trust towards adults, break that trust towards carers. The Challenging Behaviour Foundation does a lot of work around children, and I think if the individual that has asked the question is not on this call, if you are, please make sure you link in with the Challenging Behaviour Foundation. They have a lot of information around children's services and excessive use of restraint you would find very useful.
Excellent, thank you. And then the last question was, have these strategies been tried with people who have dementia, showing behaviours such as hitting and biting?
Yes, yes. So obviously, even though PBS was developed for individuals with intellectual disability and autistic individuals, actually we have found that these components can work in other populations, and maybe not every single one of these components, because obviously we have neurodegenerative disorders and quite severe physical limitations sometimes, and memory issues. But yeah, there's actually papers out there. Again, send me an email. And I'll happily share a couple of really useful papers about how we can use PBS with people with dementia.
Excellent, thank you. And I will say that the feedback in the chat is very positive. Everybody is saying it's an excellent presentation, very informative. And I have to say, I echo those thoughts. So thank you, Joe. That was really good, very engaging. Yeah, we'll definitely be inviting you back, and we'll deal with those technical demons for the next presentation, I'm sure.
I still don't know how that happened. I'm terribly sorry, but thank you everyone for your patience as well.
It happens. It happens. So it just leads me to say thank you very much to everybody for attending. Those of you that are still here, just some dates for diary, events that are coming up. And surprisingly, I'm actually going to give you a date in December, which is a little bit scary. But the first one, obviously, is our Spring Networker, which is coming up in Leeds. That's free to attend, and that's with DAC Beechcroft. And we've got, for anybody that attended the London Networker, quite similar. However, we've kind of rejigged the topics, and we will be talking about PSURF, for those of you that know that, patient safety, the instant reporting framework. We'll also be talking about CQC and demystifying their inspections and prosecutions, amongst some other subjects. That's on the 20th of March. Then we've also got the summer seminar in Stone on the 12th and 13th of June. Fun-packed couple of days with an evening meal, 9 presentations at that one, and a number of sponsors. That is a paid-for network. All the information for all of these events are on our website, NASHiCS.org. And then we've got the London Networker at the DAC Beechcroft London offices, and that is on December the 11th. Not wishing to wish away 2024 already, but yeah, there's some key dates in the diary. Obviously, we will have more webinars coming up. Just leaves me to say once again, thank you very much, Joe. Excellent. Thank you all for attending. Hope you enjoy the rest of your day, the rest of your week. And for those of you that are traveling, stay safe. Thank you.
I am so sorry. I don't know why I couldn't make this presentation work in the end.